19.
Always, we have Dr. Mike Ryan and Dr. Maria Van Kerkhove, who will be answering questions. So we will now open the floor. I will go to one question that I received by email this morning, and I promised to answer. That's Ankit Kumar from India Today. And Ankit is asking that we have recently seen a spike in cases caused to religious gatherings in India. In fact, almost a third of new cases were linked to one gathering in India. We have also seen incidents of violence against health workers due to fear and misinformation. Is WHO concerned with these developments? What is WHO's message to religious and community leaders as their followers?
First and foremost, the idea of violence against health workers is driven by fear and it's driven by misunderstanding. But it's really unacceptable, and we ask everyone in every community to see our health workers as our heroes and to support them in every way we can. With regard to gatherings of any type, be they religious or be they for other purposes, there are always risks associated with such gatherings in the midst of a major epidemic. WHO has issued guidance on that. Many of these gatherings are now postponed or cancelled. We've been working very, very closely with religious and faith-based organisations all over the world, including groups from the Islamic tradition, Christian traditions and others, and continue to work through faith-based organisations to communicate using our EpiWin platform. We're also continuing to develop guidance specifically for the holy month of Ramadan and are working through our Eastern Mediterranean Regional Office to be able to advise governments and religious institutions on how best to manage the risks associated with such holy events. But it's very important again. Having COVID-19 is not anybody's fault. Every case is a victim. And every case needs to be treated with sensitivity, as the health workers who treat them. So it's very important that we are not profiling COVID-19 along racial, along religious, along ethnic lines. This is not helpful.
Thank you very much. So this was a question from Ankit Kumar from India Today. Now we will go to journalists online. We will start with Jamie from Associated Press. Jamie, can you hear us?
Hi, yes, can you hear me?
Yes, please, go ahead.
Great, thank you very much. I wanted to just ask you about, over the weekend, Dr. Anthony Fauci mentioned that as many as, if I understood it correctly, as much as 50% of transmission could be asymptomatic. And I just sort of in line with that, if you could just give us a little bit more about what you're thinking about the fact that I'm sorry, hold on. That some countries have said that this outbreak is more infectious than influenza. As much as CDC is saying that it's up to 3 times more infectious than influenza. So, what do you have to say about that? Thanks.
I'll start, and perhaps Mike or DG would like to supplement. So the modes of transmission and the way in which this virus is transmitted is of significant interest to all of us. And what we are doing is we are working with member states. We're working with everyone that's affected by this, looking through the research and trying to understand when most transmission is happening, when any transmission is happening. And what we know from reports, what we know from published literature, is that the predominant way in which transmission is occurring is among symptomatic individuals. And these are people that can be symptomatic very, very early on in symptoms, even when they start to feel a little bit unwell. And this is supported by some data that actually tries to attempt to capture virus from individuals who are symptomatic. We also know that it's possible that people can transmit in the few days before they become symptomatic or in their pre-symptomatic phase. There have been some studies that have come out, and we learned about this when we were on mission in China back in January and early February, that there are individuals that can shed virus 1 to 3 days before they develop symptoms. However, it's very important to note that even if you are pre-symptomatic, or even if you don't have any recognized symptoms, you still have to transmit through droplets. You still have to have these infectious particles that come out of your nose and your mouth. And so while we know that that is possible, we do not believe that that's a major driver of transmission. Now, we've also seen modeling estimates that suggest that there's large numbers of unrecognized transmission. And I used unrecognized on purpose because I'm not saying asymptomatic. I'm saying that we may be missing people who are out there who are infected, but we're missing them because of current surveillance strategies. And that is certainly possible in many parts of the globe. Whether or not those individuals are asymptomatic, we will have to wait until we see results of serologic studies, which we hope we'll be seeing in the coming days, if not weeks. And so what we can say is that most people are transmitting this virus while they are symptomatic.
Hi, Jamie. Just in addition to, because I think we have, I would never in any way contradict my good friend Tony Fauci, such an eminent man. There are many different estimations of what might represent asymptomatic transmission or other infections in the community. And we do know, and everyone accepts that when the seroepidemiology studies do come online, we will probably find more people who've been infected unknowingly. There's no question of that. The thing we need to address in all of this is very often the idea of severity versus infection. And there is a huge association between the dose of exposure and the severity of infection. We see this in many other infectious diseases. So we also probably need to look at who is getting sick or very sick. And now there is the dose and the type of exposure they're getting different to those who may be exposed and seroconvert in the community. So it's not just a matter of looking at how many people in the community are infected, but are there specific elements of exposure that cause individuals to have a higher dose of exposure or a specific route of exposure that causes a more severe infection. There's also that concept of infectious dose when we talk about the different types of transmission. If somebody is exposed to a high dose from another individual directly, or from a surface that's heavily contaminated, you can imagine a large dose. In other circumstances, individual particles or virus particles potentially floating through the air, it can be demonstrated that that may happen in certain circumstances, certainly in healthcare settings. But is that significant in terms of driving infection? Is that significant? Does that produce an infectious dose that can successfully infect another individual? And these are all very important things that still need to be studied. Again, we're only a number of weeks into this. I think we need to have the seroepi studies. I think we need more information on what is the infectious dose, and particularly the relationship between the dose of exposure or infection and the severity of the disease subsequently, which has been seen with many, many other diseases in the past, including cholera, Ebola, and others.
Thank you very much, Mike and Maria. We will go now to next question. That's Kai Kupferschmidt. Kai, can you hear us?
Yes, Derek, thanks a lot for taking my question. So I just wanted to ask about, the global push to try and find a pre-exposure prophylaxis or post-exposure prophylaxis. I understand there's several trials going on, most of them with chloroquine or hydroxychloroquine. I was just wondering whether you can speak a little bit to, what role this could potentially play. And of course, also, there's a lot of smaller studies going on. Is there any way to make sure that they all lead to results that can be pooled in the end?
Maria can give you more detail, but certainly one of the Solidarity trials, I think Solidarity 3 or 4, we have one of the trials under design, which will be a multi-center study, which will look at prophylaxis in healthcare workers to see whether there's evidence that giving lower doses of drugs like chloroquine or hydroxychloroquine to health workers would reduce their risk of becoming infected in a healthcare environment. Those studies are certainly underway. And again, there are a number of those studies underway in smaller studies around the world. But again, as WHO, we're trying to bring together a larger set of collaborative studies that will give us the answers we need. In terms of post-exposure prophylaxis, I don't believe we have at the moment a studies plan, but Maria can speak to that. But there is certainly evidence for the use of, not proven evidence of effectiveness, but there are a number of studies underway and trials underway that use hyperimmune globulin in the treatment of disease. In other words, they use the plasma, purified plasma of recovered individuals to give an antibody boost to people who are suffering the disease. Similar approaches have been used in post-exposure prophylaxis for other diseases, but Maria may be aware of studies underway in that area.
Only to add that we have, as you mentioned, there are a number of smaller studies that are happening globally and across a large number of countries. We have teams through our science division and through GORN, through the Global Outbreak Alert Network, who are pulling together available literature on a number of topics, one of which is actually looking at different types of therapeutics and drugs. And the idea is until we can actually have a study that pulls together enough of a sample size to get these answers to these questions, we're trying to evaluate every piece of evidence that is published so that we could look at the way in which these studies were done. We can look at the strengths, we can look at the limitations, so that can help guide us closer towards an effective treatment for COVID-19.
Thank you very much. Next question is from BFM Radio. Is it Kate who is from BFM Radio with us?
Yes, hi, good evening or good morning. I'm actually from BFM Radio Malaysia. My question is that many countries around the world, they have imposed lockdowns or some sort of restrictions of movements of, so I was just wondering what WHO's guidance would be. What's the sweet spot, so to speak, the kind of data that governments need to consider before lifting or relaxing some of these lockdowns? Thank you very much.
Thank you. It is a difficulty for governments right now because the lockdowns in many situations are proving effective in dampening the flames of the epidemic in those countries. But those lockdowns are also causing great economic hardship. And everybody, especially in the developing world, needs to get to a more sustainable way of managing this epidemic and controlling COVID-19 without continuing to damage economic and social life. The transition strategy out of lockdown requires a calibrated, stepwise approach. It would be probably very inadvisable just to lift a complete lockdown, all of the measures, because lockdowns are a general term that include closure of schools, closure of churches, stay-at-home orders, closure of workplaces. It's a mixture of different things, and I think each government needs to break out what does our lockdown actually constitute? What are the elements of our lockdown? Where is that happening in the country? Do we now understand the epidemiology of the disease in each area in which we have an element of lockdown or shutdown? And then to chart a path out, you have to build strong public health capacity to take over from the lockdown. In other words, the lockdown is pushing the disease down by putting people back in their homes, by separating communities. Once you raise the lockdown, you have to have an alternative method to suppress the infection. The way to do that is active case finding, testing, isolation of cases, tracking of contacts, quarantining of contacts, and strong community education and participation and ownership around normal physical distancing, hygiene, and giving communities the power to control infection by in effect, managing their own physical distance, managing their own capacities to support the response. In that situation, if you have strong public health capacity, if you've got a community that's mobilized and empowered, and if you've strengthened your health system, then you're potentially in a position to start unlocking or unwinding the lockdown. The specific parameters you need to be looking at are things on two sides. One is it would be very inadvisable to lock down if the number of cases coming through the hospital are already at a level where your occupancy of beds is nearly at 100%. You need to be in a position where you now have free beds in your system so that you're managing and coping with the caseload. And that means you have some absorption capacity left. You need to look at things like the doubling rate. How many days does it take for the number of cases to double? You need to look at positivity rates. What proportion of all samples that we test are positive? You'll see in somewhere like Korea, they're testing 2 to 6% of their samples they test are positive. Last week in New York, 37% of tested samples were positive. So you need to carefully look at what proportion of people I test are positive. You need to look at the number of contacts that are generated per case. And it goes on. And WHO will be issuing guidance to countries that is much more specific around the parameters they should be looking at. There are no absolutes here. There are no answers. There are no numbers that say, if this number is this, then you do that. That doesn't exist. But what we can do is offer countries very specific measurements that they need to look at to chart the path out of lockdown. And that stepwise approach of unlocking somewhat and then waiting to see. I think you need to say we will stop doing this element of the shutdown, and then we will wait and we will look at the data. And if that works, we go to the next stage and the next stage. So a careful, calibrated, stepwise exit from lockdown with putting in place public health capacities, putting in place community capacity, building the capacity of the health system to cope should the disease bounce back up. That's the safe path out of lockdown. We want to achieve it as quickly as possible. And we want to avoid many countries going into that circumstance. And we still have many countries around the world who are not in a lockdown situation. In fact, their epidemiology would suggest they can avoid the worst of this. And we need to support them to avoid them going into that situation. The most damaging lockdowns are in many developing countries where people, as the DG has said many times, can live from hand to mouth, not from paycheck to paycheck, but from day to day. And we have to find adapted solutions around lockdown and around disease control in vulnerable peri-urban populations living in poverty, in poor rural communities. And we have to find other ways to manage, alternative, adapted ways to manage lockdowns or slowdowns or shutdowns in those situations.
Thank you very much. So this was Kate from BFM Radio from Malaysia. Now we will go to Nigeria to Metro Star, and it's Innocent. Innocent, can you hear us?
Thank you. Can you hear me?
Not very well, but we will try. Please go ahead.
Okay. Thank you for taking my question. I have two questions to ask. One, how will WHO assess Africa country and what they've done concerning the lockdown and management of COVID-19? And then the second one, there's a news going around that vaccines are to be tested on Africa when it's developed. How true is that? And is there a window that in the nearest future, vaccine will be developed for COVID-19? Thank you. Hello?
Yes, we are just trying to make sure that we understood the question. So, yeah, but we will try.
I think this is Nigeria, is it? Yes. Yeah. Maria may answer the question around vaccine development. With regard to our general assessment on lockdown, and the Director General may wish to comment on this because he's been speaking with many leaders in Africa, and I believe spoke with the whole of the African Union leadership and countries late last week. So therefore is in a much better position than me to speak about that. We would characterize, so far Africa is actually doing well in this response thus far. Countries have essential capacities for testing. Many countries are taking strong action and want to really focus on finding cases and doing contact tracing and trying to stop this disease becoming much more extensive, given the fact that health systems are not as strong in many countries. They need support in that, though. They need support in testing. They need support in with protective gear, and they need to be given the resources to be able to mount those types of responses. So I would characterise that Africa has not suffered the worst of this pandemic so far. The worst of it can be avoided with very, very swift action to support those countries in Africa who really do want to take a comprehensive approach to this disease, and with the many vulnerable people, including refugees and migrants who live in those countries, it is, I suppose, our responsibility to provide that support. But DG, you may wish to speak about your interactions with the African Union countries.
So I'll answer the question around vaccines. So what we can say is that there are a number of vaccines that are in development, and vaccines will be tested through clinical trials with all ethical considerations in place in whichever populations are under study, with informed consent, with open and transparent communication. This is of the utmost importance. Not only do we have strong, robust scientific evidence, but we ensure that all of the studies that are done with appropriate and the highest level of ethical considerations. One thing, if I could just mention on the first question around Africa, is that there are a number of countries in Africa right now which have very few cases. And Mike has alluded to this in his earlier response. Very few cases. Some only have imported cases, and there is an opportunity here. This window of opportunity that the DG has spoken about exists in many countries still. There is an opportunity to prevent the worst from happening in a number of countries across Africa and across countries that are still seeing their first case in some island countries. And we need to support those governments, those countries, all of the people in those areas to prevent the worst from happening, to prevent these individual cases from becoming clusters, these clusters from becoming community transmission.
And we do apologize for that break in the link to the World Health Organization in Geneva. But at a very, very important point that they're speaking about the health, the medical experts rather, and that is the issue of ethical consideration, especially when it comes to vaccines. You remember the furore around the alleged suggestion by two French doctors, one of them who's really gone back on that and apologized for the suggestion that a vaccine should be tested on Africa. But we'll come back with more on what the WHO has been saying, not only in violence against healthcare workers, but the kind of transmission, especially around asymptomatic people, and the prophylaxis in healthcare workers and the dosage, etc. We're taking a quick break. Do stay with us.